All right, well, good afternoon, everyone. I see we're right at 3 o'clock, so we will go ahead and get started. Thank you so much for joining us today. Let me go ahead and share my screen to just kick us off here. All right, sorry. Perfect. All right, so welcome to our September APIC Great Lakes webinar. We are so glad to see everyone here and glad you were able to make it today. So as a reminder, we do have CE credits available for this session. So if you could please put your name and email address in the chat box, we will use that to follow up with you after the webinar to get you both the survey, the post-event survey that we'll need, as well as to issue your certificate for the CEs, or if you're interested in a certificate of attendance, we can provide that as well. But again, we'll just need your name and email address to do that. So for our agenda today, we do have a full hour prepared and ready to go. So what I'll do is I'll go ahead and introduce our three speakers, share a little bit about each of them and what they'll be talking about, and then we will just kind of run through the list. I would ask that if you do have any questions, feel free as our presenters are sharing to include those in the chat box. And then we will keep a list and get to all of those at the end, but I want to make sure that we do have time for these three individuals to share a little bit about their research and the presentations they've done. And if there are any questions that we don't have time to get to, we can certainly follow up with our three presenters following the call and include any of those responses in the follow-up email that will go out probably early next week. So with that, our first session today will be presented by Jim Gauthier, titled, "Is Disinfecting Once Per Day Enough?" And so Jim currently serves as a Senior Clinical Advisor of Infection Prevention for Diversity in North America, as an infection prevention and control resource, and an industry liaison to support improvement of environmental hygiene solutions and adoption of science-based best practices. Jim has over 40 years of experience in medical laboratory technology and infection prevention across many healthcare settings, including acute, ambulatory, behavioral health, and long-term care. And Jim has been board certified in infection control since 1990. Our second presenter for today will be Dr. Salah Qutaishat, titled "Disinfectant Decision Making in Uncertain Times." Dr. Qutaishat is currently a consultant in infection prevention and healthcare epidemiology. And for the past 2 decades, he's held numerous positions in infection prevention and healthcare epidemiology. And most recently, he was a system director of infection prevention at Munson Healthcare. He is also certified in infection control and is a fellow of both FSHEA and APIC, and is also a reviewer for both of those journals as well. And then last but certainly not least, we have Jim Codman, and he will be talking about an investigation of Pseudomonas aeruginosa, bacteremia cluster in stem cell transplant populations. And Jim has been an infection preventionist for 8 years. His experience in healthcare began as a nurse tech, and really gave him an appreciation for hard work and rewards in direct patient care. He did work as a nurse in a variety of different settings, including acute care and long-term acute care as well. And as with many IPs, he at times had responsibilities related to nursing leadership and quality improvement, including those in post-acute care. And also to note as well, Jim is certified in infection control as well. So with that, again, just a reminder, questions in the chat box as we go through. We'll get to them at the end. But without further ado, Jim Gauthier, I will turn it over to you. And I don't know if you want to share your screen and flip through your slides. Otherwise, I'm happy to do that as well. So let me know your preference.
Yeah, I'll flip through the slides if you allow me to share. Is that okay if I take over the screen?
Oh, well.
Absolutely.
Just let's do it the way it is.
I'm going to change it to.
Oh.
Jim, before you begin, just a reminder for everyone on the line, if you could mute
yourself for our presenters, because I do hear some background noises. That we greatly appreciate that. Thank you.
Thank you for that. And thank you for the introduction. I really appreciate that. I'm just starting a stopwatch here so I know how long I've been talking for, so I don't want to run over. What I'm presenting today is really a 45-minute presentation trying to look at a new way of cleaning and disinfecting in our environment. So I am employed by Diversey. There are some pictures in here that we just needed for context. There's no product placement as far as I remember on this. So what I wanted to look at is the complexity that we see, with an HAI actually occurring, and talk about how we move microorganisms around that we may not be considering on a day-to-day basis, and try to propose 5 targeted moments of environmental disinfection. So for an HAI to actually happen, I've done it as an algebraic equation where we can consider healthcare-associated infection prevention to be a combination of patient acuity, hand hygiene practices, antibiotic stewardship programs, clinical practices, fecal waste management, and environmental disinfection. Now, in many cases, we know of some of these things, but I've added some into the equation here for us to consider in this presentation. So again, this is a full 45-minute presentation that I can do another day for you. But in terms of patient acuity, I'm talking about patients that are on a ventilator, they have a portal of entry, young and old, on antibiotics, comorbidities. When I talk about hand hygiene, do we have a good program in place with the right product in the right place? Do we audit that people are doing what we thought they were doing? Do they truly know the 5 moments? Do we have a champion on our different areas to make sure that hand hygiene is as high as possible? Do we even consider patient hand hygiene? And do we discuss the role that family and visitors can play in hand hygiene? Antibiotic stewardship program. Do we have the right drug by the right route for the right duration at the right dose? And do we have restrictions on our formulary so that we don't use antibiotics that may precipitate things like C. difficile? Clinical practices. What are we using for skin prep? Is it the most effective product that's currently available? Do we decolonize our patients if they are in certain areas of our hospital? Are prophylactic antibiotics pre-surgery? Is that on board when it's supposed to be? And do we audit that? And do we have good bundles in place that are up to date? Because they have made a huge difference in some healthcare-associated infections. Fecal waste management, I spend a lot of time talking about feces, it seems. But what do you do with your container, your bedpan, your commode bucket? Because if you don't have readily available PPE for anything to do with feces, so if I'm working with a patient that has a colostomy, do I have readily available personal protective equipment if the patient's not on contact precautions? Do we have a no rinse policy for bedpans and commode buckets within the patient's bathroom? Do we have a written protocol on how we handle feces? Because most facilities don't. And again, full 45-minute presentation on this also. Environmental disinfection is a large part of the equation. Does EVS know what to clean? Do we audit that? Do nursing know what they can clean? Does everybody know what their responsibility is for cleaning either their equipment or parts of the environment? Can family play a role in using wipes if they were in the room? Do you have a product that people want to use, or are they afraid of it? If your product requires PPE, is it readily available for people to use the product? Do you follow the contact time? If you're using a dilutable product, do you check that that's working? Is your product compatible with the surfaces you do need to disinfect? And do you have enough people to do it? So for HAI prevention, I position that there's at least 36 factors that can feed into it. And many times what happens, we get stuck on hand hygiene. And I've heard patient advocates say, if we can get hand hygiene to 100%, all infections go away. Well, hand hygiene controls for about 7 of these. And we focus on EVS. Let's audit that our EVS people are doing what they're supposed to do. EVS sucks. We can't get anything done in our hospital and we had an outbreak. Well, truly, EVS only controls 9 of these factors. So what I'm proposing here, if we can get that up to 24 of our variables covered through what I'm proposing here, I think our patients would be much safer in our healthcare setting. So the patient environment, what happens after the EVS tech leaves the room? They come in, I'm being very generous saying they get half an hour, but what happens through the rest of the day? So we've gone through some different papers and looked at it. The Cone study here from 2012 looked at what happens in a patient's room between waking hours, and they found that on average, there's about 5.5 entries into the room an hour. So through the course of a day, we could see 82.5 people coming in and out of a patient's room, which is a lot of people moving in and out if we're only cleaning once a day. What do they touch while they're in the room? Kirk Husledge did a great paper looking at what are high touch surfaces. And in his study, just watching interactions, that's somebody walking into the room and walking out again. In an ICU, the bed rails, bed surface, and supply cart were the high touch surfaces. On the med surg unit, bed rails, over bed table, IV pump, and bed surface. What I found interesting as a lab technologist is the bed rails touched 3.1 times on average per interaction, which I'm thinking, okay, that must be me putting my hands on the handrail to say, are you the guy I'm taking the blood on? Then putting the handrail down, that's 2 touches, do the phlebotomy and pull it back up again. That's the best I could figure. Where did they get the 3.1? But put these together. If we have 5.5 entries per hour and every entry on average is 3.1 contacts of the bed rail through 15 hours could be touched 256 times a day and cleaned once if we're lucky that our EVS staff are using a product they're not afraid of and aren't afraid to put it near the patient. So if we disinfect once out of 256, my question is, what happens to the other 255 contacts of that bed rail? Now, I was traditionally saying that's a little large number, and I actually had Dr. John Boyce phone me up after hearing my presentation saying, Jim, you can't say 255. You can't put 2 studies together like that. And I said, Dr. Boyce, respectfully, let's cut it in half and say we touch the bed rail 125 times a day and clean it once, or cut that in half and say, listen, we only touch the bed rail 60 times a day and clean it once a day. Is that better? And he said, well, not actually. Then I found the Gauthier study from 2017 where the bed rails were touched 375 times in 6 days. For the math people in the room, that's approximately 60 times a day, which supports my premise, plus the overbed table being touched 223 times. What's scary on here is the devices that go from room to room to room. Workstation on wheels, vitals machine in 6 days was touched 847 times. Only disinfected 17 times, which is 2% of the time of use. So if you're seeing bugs move through your facility, take a look at this, because what they noted in the Gauthier study is we touch the patient to the bed rail and the bed rail to the patient most frequently as a series of touches. So does your clinical staff disinfect every time they touch the environment around the patient? Do they disinfect based on the care that they provide? Probably not, unless it's visibly soiled. They may take a wipe if they see feces on a handrail. So our hand hygiene compliance, I'm being generous at 40 to 60% if we're not standing in the room. So what I'm trying to propose here is we got to recognize there are high touch surfaces that have to be done more frequently than 24 hours, once every 24 hours. And perhaps there's certain procedures we do that we need to disinfect surfaces either before or after those procedures. So my standard precautions in a nutshell is if they are leaking, protect yourself and limit their movement. If it's dirty or you used it, disinfect it. That's my standard precautions. That applies to almost any situation I've come in. If a patient's got vomiting, diarrhea, a wound dressing that's being soiled through, protect yourself, gown and gloves, which is contact precautions, which is limit their movement. If it's dirty or you used it, disinfect it is the message I'm going to try to carry here through the rest of the presentation. So we have this conversation in diversity all the time, and we're saying it's everyone's job to disinfect. But it's not everyone's job to disinfect everything every time, because I get pushback all the time from our end saying, don't give me one more thing to do. And I'm saying you have a role in disinfection, not everything. I'm not saying you're becoming an EVS like we had to go to in some cases with COVID rooms, but it is everyone's job to disinfect. Why do I say that? Well, Jim's back to his feces again. Did you realize a gram dry weight of feces can have 1 × 10⁻12 microorganisms in it, and 1 ml of saliva can have 1 × 10⁸ organisms per ml? And if we start looking at what happens to our environment, I went through some studies to look at what we can find on bed rails or the controls, or what we can find on overbed tables. Yes, Jim found 22 studies that looked at what we found on bed rails: FSHEA, MRSA, Clostridioides, Acinetobacter, KPCs, MDROs, just bioburden, even Candida auris can be found on a bed rail. These are usually done during outbreaks. What's on the overbed table? 13 studies looking at what they found on overbed tables during outbreaks. I'm not going to go into these in great detail. What I do want to pull to the forefront here is a paper by Dr. John Boyce from 2007, where they actually quantitated MRSA in feces. And when it was present, they could find it from 10 million to 1 billion colony-forming units per ml of liquid stool, or per gram of stool. Well, 1 ml is 1 gram, but I'm Canadian and I know that. So I didn't really realize MRSA could be linked to feces. This is another study where they were culturing the environment, bed rails, bedside table, bed controls, just looking for C. difficile in the known positive C. diff patients and not in a room where they didn't know the patient had any C. diff at all. They probably had tested negative. And after terminal cleaning, 4 to 6% of the surfaces still had C. diff spores on it. And I know we tend to panic about C. diff spores. What did they find on the floors? Deshpande did this great study where they cultured the floors of C. diff rooms and non-C. diff rooms, found spores of C. difficile in the red bars. Those are the non-C. diff rooms. 45% of the rooms had C. diff spores on the floor. What they also did in the study is found stuff that was on the floor, picked it up, and then cultured their hand or their glove, and found that you could move MRSA, VRE, and C. difficile from the floor if you picked something up and didn't clean it. So this is where my concept of everyone's job is, it is everyone's job to disinfect comes from. But when do I think we need to do it? We tell our staff when they have to perform hand hygiene. My analogy is we don't tell staff to come in first thing in the morning, scrub their hands for 3 minutes and never wash them again through the rest of the day. We give them 5 moments from the WHO or 4 moments in Canada when we absolutely need to see hand hygiene done. So my targeted moments of environmental disinfection mimic this. My first moment is before we put food or drink on an overbed table, I think it needs to be disinfected. My second moment, before and after aseptic practices. So if we're doing wound dressings, inserting lines or line dressings, anything aseptic, checking a urinary catheter, let's disinfect before and after. Number 3, after any procedure involving feces or respiratory secretions within the patient's bed space. You go in to suction a patient, you should disinfect something afterwards. Moment 4, after patient bathing within the bed space. I've got all these studies that show why all of these procedures are contaminating. I can't show that to you in the 15 minutes here. The paper listed at the bottom goes through all the evidence of why I'm proposing these moments. And moment 5, after what you saw with the Deshpande paper, after any object used by or on a patient touches the floor, it needs to be disinfected before we hand them back their cell phone charger, the call bell, the blood pressure cuff. So like I said, that's summarized in the paper listed there. After my paper was published and I put this presentation together, there's a recent paper from 2020 that looked at contamination close to the patient after certain care procedures. And it was amazing how well it mimicked what we were proposing. Wound care, which was moment 2, aseptic. Meal assistance, moment 1, is what we proposed. Urinary catheter is an aseptic practice. Ostomy change is feces, that's moment 3. Bathing even showed some contamination, and they were looking for multi-drug resistant organisms here. So there's more papers coming out that support this concept of cleaning more than once a day. This is familiar to your staff. You know, they've seen this all over the place, and what we're proposing is doing much the same thing for point of care disinfection. Before placing food or drink, before and after aseptic, any procedure involving feces, respiratory secretions, after bathing, and after that thing touches the floor. We actually developed, and we put this in the paper, a chart. So you can go up to your team and say, okay, who feeds the patient, first of all, because it's not RNs. They're the ones that are going to push back. But we actually went through this for a patient that was on a med-surg floor with no wound. So let's be nice and feed them 3 times a day. Feces, we hope they defecate once a day. If they don't, we make them do that. We bathe them once a day, so that is just nice to do to people. And maybe they've dropped 4 things. So we're talking maybe 9 extra wipes a day. How many of these does the RN actually do? And that's why this table was designed. It's not an onerous procedure. The way we start it simply is, if you've touched it or used it, disinfect it. As Mr. Phlebotomy going in here to take someone's blood, I go in with my workstation on wheels, I lower the bed rail, put my kit on the overbed table, do my phlebotomy. I've touched the workstation on wheels, the bed rail, and the overbed table. 1 wipe, do all 3 surfaces, take off my gloves, leave the room. To me, that's not onerous, but to get this started, we need to get brackets in the patient's room. That's the first start with any kind of a procedure like this. But then you've got to look at what your disinfectant is. You need to have something that you can leave at point of care. So if you can find a product that's got that 000 HIMAS rating or an EPA toxicity rating of 4, you can leave it in the room with no plaque card, because really it's not harmful to health, not flammable, there's no physical hazard. You don't really need to use gloves or PPE to touch the chemistry. You know, staff will use gloves as per standard precautions, obviously that way too. If you've got a product that has a higher HIMAS rating than this, you're going to have a plaque card up saying, if you want to use our product, you're going to have to be careful with it. Having it convenient will make it work. We learned this so much during hand hygiene when we introduced alcohol-based hand rub. It has to be attached to mobile equipment. It has to be readily available. So what I've showed you here in my 14.5 minutes is HAIs are multifactorial. And frequently we get stuck focusing on hand hygiene auditing and environmental auditing. We know the environment is touched numerous times throughout the day by everyone, and microorganisms are going to move. So I really am proposing that cleaning and disinfection need to be part of patient care practices, because just doing it once a day is not enough. We can't put the sole burden of cleaning on EVS. Everyone has a role. And TMED is proposing a way to do this in the near patient environment to keep it cleaner. There's 5 moments that we've got listed here. I think if we can implement this in a simple manner of if you've touched it or used it, disinfect it, will get us to these 24 variables that we want to see here. There's my contact information. I didn't put Chuck on here, unfortunately. This was from the actual presentation we did. Hopefully there'll be questions at the end of this when we're all done.
All right, Jim, thank you so much for your presentation. That was a packed 15 minutes, but really appreciate all of your insight. And again, as we mentioned at the top of the hour, for those who are listening into the call, if you do have questions, please feel free to put them in the chat. We do want to save time at the end, so we'll keep a list of those questions and circle back with our presenters to go through those questions at the end. So I will now turn the floor over to Dr. Salah Qutaishat. Thank you for joining us, and the floor is yours.
Hello, can you hear me?
We sure can, thank you.
Okay, perfect, thank you. And first, I'd like to thank the Jim for this great presentation, the organizing committee for inviting me, and most importantly, I'm going to take a second or two to thank all of you for everything that you've done in the past. I call it 2 years, but people correct me and they do months, but it's an approximation. What the infection prevention community is going through is tremendous, and I feel your pain, and we're all in this together. Next slide, please. So I want to, I'll try to do the 10-minute version of this. I have nothing to disclose. I also presented this with a partner, Mark Oliver Wright at APIC. Next slide, please. Here's a list of objectives, and I usually skip through this, but really what I'm going to impress you with is kind of a different twist on cleaning and disinfection. And most importantly, during a pandemic, especially in the early days of the pandemic, when resources were not available. Next slide, please. So here's my slide. I prepared the slide many years ago, and it really brings together the two key elements of hygiene, environmental hygiene and hand hygiene. And I'm gonna, and how this is the chain of infection. You remember that? I changed it into a simpler diagram that fits into my philosophy in transmission, and I'm gonna show you evidence that this makes sense. I'm gonna add one thing for the COVID world is the air hygiene, which is really significant. And I'll update this slide in the near future. Next slide. So key to one of the studies, and that's 10 years ago, the Donsky group in Cleveland showed that the gloved hands of a person mimic the environmental sites when they looked at the positive cultures and the colony forming units. So what this, in summary, there's no significant difference on contamination rates of gloved hands and contact with skin or environmental surfaces. The skin of the patient, the environmental surfaces, and the hands are so intertwined. And for many of us who took care of patients, understand that we touch, and things kind of spread. Next slide, please. So what is the ideal disinfectant? And Rotella, who there are a few people that do research in this area, and Rotella is one of them, looked at a paper that he published more than 5 years ago, and looked at the description of those ideal disinfectants. But I'm not going to go over all those details. I'm going to take you to the next slide because I see the world differently. I'm not into lists. I'm into simple diagrams. It's a disinfectant that takes care of the microbes, but also is safe for the people, and it's also safe to the assets. So there's a soft spot somewhere where we can actually hopefully we'll be able to find a product that meets all these requirements, because a product that is harmful to healthcare workers is not going to be used. And if it destroys the assets, i.e. the furniture, the beds and the assets within the patient room, it's not going to be also used appropriately. But it has to also kill those microbes of interest. Next slide, please. So here's a slide that summarizes the existing, and this is just a sample of those disinfectants that are available with their safety profile. And I'm not going to dwell on that, but I think the most commonly used until recently is the quat. Quats, or quaternary ammonium chlorides, are the cheapest. Yes, they have issues mainly with dwell time. Then phenolics, that's an old thing. Hopefully I'll get to that later. And then there's the hydrogen peroxide, bleach, and then the accelerated hydrogen peroxide and peracetic acid, because those are kind of the newer players. I don't want to forget about what I call them the combo disinfectants, i.e. mixing quat with alcohol. Next slide, please. So I'm going to take you to, that was the past, the future, and there are many companies that are working on developing products that are what's called the new line of products, continuous active disinfection or disinfectants. And the reason why is that we struggle with how often do we disinfect, when do we disinfect, is daily disinfection the right thing to do, is twice a day, 3 days a day. I think what we were always asking for is something that stays on the surface, active on the surface for a long period of time. And those are the products that are being marketed now. I really don't know which company is marketing them, but I'm going to take you to the research that supports the use of those products. And the key is persistence on the surface. They add the product to a polymer and it stays on the surface for a longer period of time. Next slide, please. Here's the study again by the group in Cleveland, the Donsky group, that shows the activity, compare the quat to the continuous disinfectant. And I think the disinfectants are approved now, EPA approved for 4 days, but it shows that this activity continues for 7 days. And I think it's important for us to remember that quats also have some persistent activity. That's the orange column. And Rotella many years ago showed this, but then they're not EPA approved for that length of a time. So I think this is something that adds to the evidence that quats persist, but if you add a polymer, you end up with a product that really very effective for at least 4 days. Next slide, please. And here's another slide that shows
Dr. Qutaishat, I think we might have lost your audio. You want to try maybe turning your camera off, but keeping your audio on to see if that helps resolve? I know you mentioned you were having some tech issues. All right, I apologize. It seems like we've lost Dr. Qutaishat. All right, so I was hoping maybe he would dial back in, but in the interest of time, Jim Codman, I wonder if I can kick it over to you while we work to get Dr. Qutaishat back on the line.
Sure, I can start. Do you want me to start sharing my screen?
That would be great. Thanks, Jim.
Sure. Okay, are you able to see that?
We sure can.
Okay. All right. Well, good afternoon. I'm sorry about that little hiccup. My name is Jim Codman. I'm one of the infection preventionists that works at Spectrum Health in Grand Rapids. And I wanted to present this description of an investigation. I'm calling it a long and winding road, an investigation of a Pseudomonas aeruginosa bacteremia cluster in a stem cell transplant population. Called it a long and winding road because it took us to places that I wouldn't have necessarily thought of when we started. And we wound up in a destination that I wouldn't necessarily have guessed. I do want to say that this is also a condensed version of a presentation, so I'm not going to cover all of the slides, but they are available. They'll be available, I'm told, in the slide deck for those of you that want to take a closer look at some details. The objectives for the presentation are for folks to kind of think about three sources of potential contamination from Pseudomonas in a healthcare setting, maybe in your area. You can think about those as we go along. And then 5 things that you could possibly do, interventions to reduce the risk of Pseudomonas contamination in your area. Hopefully I'll give you some ideas and maybe jog your thinking a little bit from this presentation. And then listing some basic steps in an outbreak investigation. Don't worry, I'm not going to go through all these steps, but the slide I put in to show how intimidated I was when I started with the suspicion that we had an outbreak going on, and the concern about where do I start, what do I do, where do I go next. So I think it's helpful to have some resource, whether that's from APIC or from the CDC, or maybe your own healthcare system has a policy or procedure you can use to help guide you. That's very helpful, I think. Our situation was that from May to September of 2020, we had 9 patients that were identified as having positive Pseudomonas blood cultures on our adult hematopoietic cell transplant inpatient unit, our HCT unit. One of those steps in the outbreak investigation is to come up with a case definition, and ours was hospital onset Pseudomonas aeruginosa blood cultures greater than or equal to hospital day 3 among patients on that stem cell transplant unit. And I'm going to just kind of skip forward a little bit here. Our really smart epidemiologist at our facility, who happens to be Chow, put together this really helpful graphic. And this shows a timeline that we had in which we had our first case, if you look to the left, back in May of 2020. And the green icon person represents a transplant patient that is an allogeneic transplant patient. So that would be a transplant patient in which the donor and the recipient are different people. And then the red icons are the autologous patients in which the donor and the recipient is the same person. The patient is using their own cells that were donated earlier in the process. So you can see we had a case in May, and then we had a couple more cases in June, and then we had more cases in July, and I was getting increasingly nervous and concerned as this was going on. And then we had more cases in August, and then one in September. And you'll notice that the bulk of the cases, 7 out of 9, are the autologous patients. So kind of keep that in mind as we go along. We looked at durations of things. So from admission to positive culture, we had a range of 3 to 13 days with an average of 9. from line insertion, because all these people, all these patients had central lines, which we knew was a pretty big risk factor. From line insertion to positive culture, the range was 10 to 36 days, with an average of 23. One patient actually had a line that was in place for over a year. And then from admission to discharge, the range was 13 to 33 days with an average of 20 days. One of the first questions we asked was, do we need to refine our case definition? Is this a problem, a larger problem than we think? So we looked at our Pseudomonas rates for the hospital, the entire hospital, and over this time period, and found that there really wasn't any kind of significant peak or elevation during this time. We looked at the other hospitals in Grand Rapids in our system, the 2 adult hospitals and our children's hospital, and they also didn't have an increased Pseudomonas culture rate, which was reassuring to us. It was only when we looked at that particular unit, which is the blue line, when we separated that out from the rest of the hospital, the rate, the hospital rate is the green line, and that unit rate is the blue line. So we knew that this was an isolated problem to that unit. We then asked, well, is it a Pseudomonas issue on that unit, or is it maybe also including other waterborne pathogens or bacteria that like to live in a moist environment? And if you look at the green bars, it shows that it was really a problem related to Pseudomonas. So that's where we focused our efforts. If we went back to that slide that lists the outbreak steps, one of those steps is to observe and review potentially implicated patient care activities. So one of the things we did was we did an anonymous staff survey, asking mainly nursing staff, but also others as well, some specific questions. This was all anonymous. I won't go through all of them, but one of them was, how do you prioritize changing a non-intact central line dressing? And our hope was that people would answer that the question that has the aqua bar, change immediately. We found that just under 50% of people said that. So we knew that we had some opportunity for good practice. We asked other things like, how often do your patients with central lines have dressings that are wet, such as from a shower or bath? And that happened sometimes in about 45% of people. So we knew there was some opportunity for improvement in care. We also looked at the clinical practice related to those stem cell transplant patients. And interestingly, this is the patient days on that unit. You can see that starting in about March or so, there was a dip that corresponded to when COVID was ramping up. That program was dialing down their transplant number just out of concern for what was going on with COVID and protecting their patients when possible. So we were seeing fewer patients right before that cluster happened. When we looked at our practice, we found that, remember back to that slide with the green and the red icons? Well, the allogeneic patients, those green patients, are at actually higher risk for infections than the autologous patients, the ones that donate their own cells, in normal transplant situations because of their longer neutropenia and longer hospitalizations. We were actually seeing the reverse though. We saw more infections in that autologous group, which was puzzling. We did learn that in June, sort of right at the start of this whole situation, there was a change in an antibiotic that was used from a levofloxacin to cefdinir as part of a prophylactic cocktail that's used for these patients. And that was really an effort, a really good faith effort to reduce our fluoroquinolone use as part of hospital antibiotic stewardship to potentially help our rates of hospital onset C. diff. Looking back, we know that the levofloxacin has a greater activity against Pseudomonas than the antibiotic that that replaced it. So that was an important thing we learned in our deeper dive. But both groups of those patients had that same antibiotic change. So again, a little puzzling as to why it was only showing up in the one group. We did some environmental rounding, and we used that results along with our staff survey to create this educational flyer. I'll let you kind of take a look at that in detail on your own. Some of the things we noticed in our environmental rounding was that the Paul water filters that we had in place from more than a year prior actually, were being used appropriately. They weren't expired. We did remove a slushy machine on the unit because of concerns that it could be a means of contamination for a waterborne organism. We did start some bleach flushing of our sink and shower drains on that unit. And in addition to just re-emphasizing the importance of hand hygiene, we had staff use a CHG hand soap to at the start of their day and after lunch, really to take advantage of that prolonged CHG action in our effort to minimize hand contamination. We also found in that long and winding road, that road led to some hidey holes, like a cupboard that was stored this white, you can see that white container that with the green label. Well, that was a massage therapy container. It's a pretty large container. When I took the top off, I noticed what was in that picture on the right with the spoon sticking in the lotion. So people were taking lotion out and putting into that other container with the faded red label, looks kind of old, refilling that container, taking it into multiple patient rooms. So we stopped that process. We also took a look at the contracted company that actually processed the blood transplant product and brought it to the hospital patient room and thawed it so that it could be infused into the patient. It's kind of hard to see, but that picture shows a gray box on top of a cart, and that gray box is actually a water bath thawing machine that was used to thaw the product. So in partnership with that contracted company, we came up with some suggestions for better process to minimize potential contamination. We also confirmed with them that they weren't seeing other facilities that they supplied product to having similar issues, which we were happy to hear. This winding road also led us to our own lab in which we took a look at our blood product thaw process. And I don't know if those of you who maybe have experience in a blood bank or a lab might recognize some of these machines. They were new to me. The one on the left is an older machine, and you can see it's got some yellow sleeves, these envelopes that the frozen product is placed into, and the warm water bath inside the machine sort of rises up and thaws the product. Ideally, you don't want the water inside the machine to touch the blood product container, but you can see from that middle photo, these sleeves were discolored. When I tried to take one off, it just cracked. It was so old. There was I'm guessing some growth underneath there. Fortunately, our lab had some other machines that they used and then actually purchased more of to replace that older machine. We used some environmental sampling as well as the culture results from 7 out of those 9 patients to send for whole genome sequencing to see if we could find some evidence of relatedness between those strains that the patients were ending up with as an infection. And from that analysis from the state, we found that we did have one event in which 2 patients who'd shared the same room, separated by many days, had a related strain. Other than that, and I think this was more significant, all of our environmental samples from things like drains, from water sources, both before and after the filter, from our massage therapy container, took a sample of that, from our water bath. All of those, I should say, none of those environmental samples matched the patient samples. Some of the environmental samples matched each other, but none of them matched the patients, and then none of the other patients matched each other as well, other than the two that I mentioned first. So it showed us that there wasn't any kind of larger scale transmission event or like single source that we were passing around in the hospital, which sort of made the puzzle kind of even bigger. We did have a hypothesis based on all of this, and that was that our autologous patients, those that had the bulk of the infections, had some pre-existing colonization of the GI tract with Pseudomonas, probably due to prior broad spectrum antibiotic exposure, which all of those patients have. Those patients also underwent a specific kind of conditioning before their transplant with a certain medication that can damage the GI mucosal barrier. So that GI mucositis combined with the change we made to the antibiotic that allowed Pseudomonas to grow in patients who already had it, kind of combined in those neutropenic patients to allow that growth in the intestine to move, to translocate from inside the intestine into the bloodstream, and then causing bacteremia and CLABSIs. Our hypothesis was supported in that after we switched back to that original antibiotic, we had no further infections. We did, if you remember from that slide with the green and the red people, we did have one case that was actually from prior to the antibiotic switch. And our thought was that that was probably unrelated to this cluster and may just have been a background, part of a background infection, number of infections related to Pseudomonas. That patient was also not an autologous patient, which made them a little bit of an outlier as well. So what are we doing now? Well, we're continuing to use our original antibiotic prophylaxis. We did adjust our recently instituted practice of drain bleach flushing from weekly to at every patient discharge. And we continue with our encouragement of staff to do good hand hygiene. We continue to do the CHD hand soap. And then we are also continuing to practice those good, use those good practices that we educated in that flyer that I mentioned. And then infection prevention is continuing to monitor things to see if we have recurrence. And that's actually the end of my presentation. And if you do have questions, I'd be happy to answer.
Great, thank you so much, Jim. So I do see there's a question from other Jim in the chat here. I want to make sure we loop back to Dr. Qutaishat since we lost him mid-presentation. So Dr. Qutaishat, are you back on the line with us now?
Yes, can you hear me?
I sure can. Awesome.
Okay.
I'm glad you were able to rejoin. So I will go ahead and share your screen.
Yeah.
This is where we left off, and I will turn the floor over to you.
Yeah, so let me take some time to tell you that we had a power outage here. So the lights went off and I kept talking because my computer is on battery. And then I realized that the internet needs that power. So lesson learned, when the power is off, it means that you're off. Also, I remember asking to be the sweeper. And for those who don't know me, I have that power. That's why the power went off, because I wanted to be the last speaker. So putting the joking aside, I'm gonna do a quicker version of that 15-minute in the next 5 minutes, take you through many of those slides, and then take you to what I learned from my mom. And that's really the key to this presentation. And next slide. I think most of you are familiar with this old slide about how disinfectants work, from the hardest to kill to the easiest to kill. This is the cornerstone of how we really deal with disinfectants when there's an emerging pathogen and there's no label that says this disinfectant works. But next slide, please. But the EPA has a process, and the EPA is the government agency that approves disinfectants. And it's mind-boggling for me that the EPA is in my mind, it's the wrong agency. And I'll talk about this in a few seconds. Next slide, please. So the EPA kind of uses that hierarchy to give an emergency kind of approval for disinfectant when there's no, the label doesn't have that disinfectant listed. Next slide, please. Just a reminder, when it comes to viruses either are enveloped or non-enveloped, and that's really the key. And the enveloped viruses have a lipid outer layer, and they're easier to kill. So in general, almost any disinfectant kills viruses that have an envelope. Next slide, please. So what happened during the first phase of this pandemic is that there was a supply chain issue, and you're all aware of that. We couldn't find supplies, we couldn't find anything, and I'm going to address how to deal with this in the future. Next slide, please. So the key is inventory, and I think we as infection preventionists need to be on top of this, not just depend on our supply chain group or our EVS. We need to understand the inventory and how much supplies we have and how long they last, and then create standards for use. And I'm not, if you remember those 2 points, then you'll be ahead. The CDC has apps for masks. Use the same app for disinfectants because it applies to making sure that you have enough supplies for whatever period of time that you need to basically a stock in place. Next slide, please. So here's what I learned from my mom, and that was a long time ago. At level 1, and in case of an emergency, think about soap and water and scrubbing. This is the old-fashioned way of cleaning. And I think many of us forgot about this, or we were convinced that this stuff is not good enough. The truth is, it is good enough. And here's the evidence. There's physics, chemistry, math, biology. My mom did not finish 4th grade, but she knew all this stuff. Then when she upgraded, she went to bleach. And we all now know that bleach works. If we label it, if we use the right dilution, it works. And my mom used to call Lysol. I don't know why, but Lysol was her 3rd phase, which is the phenolics. And I don't recommend this. I think it's the smell. If it smells worse, excuse me, in her mind, it works better. Next slide. So, excuse me. Here's the dilution of bleach. I think it's important to focus on safety for employees and not ignore that this is a product that needs, if we make it in-house, we need to train people and not just rely on a piece of paper that says make 1 to 10 dilution bleach. Next slide. I'm going to share with you what I did. Remember that toilet paper shortage? What I did, and I use this as an example of how to deal with shortages and supply chain issues. Inventory, this is at my house. Looked at usage, how many rolls did we use a week? Created a process to optimize usage, so reduce waste. Did a lot of research on what did we do before toilet paper. And I found out that we actually used to use a washcloth and newspapers, and we had a contingency plan. And when the key is when to activate this plan, it's when the threshold reaches a certain level. And we did a lot of training at my house. So we looked at the number of washcloths that we have. We trained everybody in the house on how to use them because they're used to use toilet paper. And then we made sure that we had a balance of inventory of washcloths, and then made sure that we have detergent to wash the washcloths. So we didn't use newspapers because in the digital age, newspapers became obsolete. Next slide, please. So how to prepare for the next crisis? And I think it's important for us to look at what we've learned from this crisis and apply it to the future. So a risk assessment is important. This applies to disinfectants, but it also applies to any other supplies that are important in infection prevention. And what makes sense is, after the risk assessment is performed, look at a risk stratification and perform efficacy and validation studies. So if you use, for example, in your an example of the risk assessment, if you say we're going to use soap and water, and here's the concentration of soap and water, do work with your partners on ensuring that this product works. You have laboratorians, some hospitals have relationship with research, the academic centers. Do your research, actual research, not the internet research, and make sure that you actually have everything in writing to show that this contingency plan is based on science and not based on fiction. And I'm going to stop here because I think we're reaching the hour, just for the sake of time. Thank you.
All right. Well, thank you everyone for joining us today. And then especially a thank you to our 3 speakers for your time this afternoon to share with us your presentations and abstracts that you presented at National APIC this year. Just a few slides for closing out to our members. Kelsey, can you share the slide on the screen for me? So what's new is that we have began recording each of these webinar sessions. So the PowerPoint slides will be posted on our APIC Great Lakes site. And the link to the site is on this slide here, which we will send out to everyone. And then we have a new YouTube channel. So you can also access our YouTube channel, and then all the webinar recordings will be posted to this YouTube APIC Great Lakes channel. So don't forget to subscribe to our channel. And then just a reminder, save the date. So Tuesday, October 19th, again, from 3 to 4 p.m., we will have our October webinar session, and we're very excited to have Ellie, who is the NHSN epidemiologist at the SHARP unit over at the state. Ellie will be sharing with us the healthcare associated infection and the COVID-19 pandemic. So she's going to provide a summary of the Michigan data that has been reported to NHSN, and kind of, you know, openly discuss about the data and how the Michigan data compares to this the nation. So we look forward to seeing you guys on Tuesday, October 19th. And then again, if you guys have any questions for our 3 speakers today, please feel free to reach out to Kelsey and I with our email address, our display on the screen here, and then we can forward those questions over to our speaker and get them answered for you guys. So once again, thanks everyone for joining, and wishing you guys a great Tuesday afternoon. Have a great rest of your week.